Right, so moving on. So, just a quick reminder about neuroendocrine tumors, and I'm sure you've heard this in many different ways from many different people in different lectures. But neuroendocrine tumors are tumors that arise from neuroendocrine cells. Split down simply, that means that these are cells that receive a signal from the nervous system and release hormones. Hormones, of course, are substances that travel throughout the body and affect changes in the body, things like breathing and digestion. Now, the interesting and important thing about these cells is that they're distributed widely throughout the body, and so neuroendocrine tumors can arise from multiple different organs. The most common sites that they arise from are the small intestine and the pancreas, but we see tumors also arising from the lung, sometimes from organs like the thymus or thyroid gland, and even from places like the ovary. So these tumors are what makes them so interesting from a medical point of view and so challenging from a management, diagnosis, imaging point of view, is that they're so varied. So not only do they arise in lots of different organs, but they affect young people, they affect old people, male and female. They can grow in different ways. Some of them grow very slowly, some grow very quickly, some are large, some are very small, but can release hormones which can have huge effects on patients, producing these sort of chemical, syndromes, these hormonal syndromes. But one thing most of these tumors have in common is that most of them have something on the cell surface of the tumors called somatostatin receptors. So basically, a receptor is like, you can imagine like a key on the surface of a cell, and things will come along that will fit into that key. They'll bind to that key, and they will make that cell then produce an effect like releasing a hormone. I'll talk a bit more about somatostatin receptors later, but the most important thing about them in this context is that they provide us with a target. They provide us with a way to image neuroendocrine tumors and then also a way to treat neuroendocrine tumors. So, conventional imaging. Conventional imaging is a broad term that we use for things which don't include the functional component like PET. So these are usually things like ultrasound, CT, and MRI. They've got different roles at different points of the journey. Often they're used to diagnose disease. They may be the first modalities that find disease. They can identify the primary. So the word primary is used when we're talking about where did the cancer start. The site that the cancer started in is called the primary site of disease. They can also identify metastases, and those are sites that the cancer has spread to. We can use these imaging modalities to monitor changes in disease after treatment. So ultrasound, most of you will be familiar with. Many people will have had an ultrasound, perhaps as part of a pregnancy ultrasound or for other reasons. And it's often one of the first imaging modalities that people encounter. It's used as a really common way to investigate patients with symptoms. So that might be weight loss or abdominal pain, for example. And it's got a lot of advantages, mainly in that it's readily available. Pretty much everywhere with any kind of radiology service will have ultrasound. It's really quick, there's no radiation involved, and it can give you really nice images of what we call the solid organs in the abdomen, so things like the liver and the kidneys in particular. Disadvantages, it is operator dependent. So it depends a bit on how easy the sonographer found it to get images at that time. And that can be affected by things like the size of a patient, how bright and echoey their fat is. And for example, if the patient has a lot of bowel gas present at that time, it can make it hard to see the organs. It doesn't visualize bowel very well on its own, so it's not really good for looking for things like small intestinal lesions. And the pancreas is particularly challenging on ultrasound just because of the anatomy, because of the way that the pancreas lies in the abdomen. It heads quite far towards the back and it can be really difficult to see. People might encounter ultrasound later on when it comes to, for example, obtaining a biopsy. That can often be done using ultrasound guidance so that we can see the lesion that we're putting a needle into to make sure we're getting exactly the right spot. So ultrasound will give you this kind of image, and they're usually static images. That is, a one-off, not moving image. So you can see that no matter how many images you can take, there's the potential that there will be small or subtle findings that we won't capture on that particular image. And this, for example, is a picture of the liver here. And this structure is one of the kidneys. Computed tomography, or CT, is really our absolute workhorse. This is our day in, day out, our bread and butter. And it's incredibly good at what it does. It's used for diagnosis, so that might be a finding seen on ultrasound that we're going to look at on CT, or it might be for investigation of symptoms, again, for example, like abdominal pain. We find actually a large number of neuroendocrine tumours as an incidental finding, and that word incidental means that the purpose of that particular scan wasn't for this tumour, wasn't to find this abnormality. It was to investigate something else. So, for example, we often have patients who present with symptoms that are concerning for an abnormality involving the aorta, but we have on multiple occasions found in those patients findings that lead us to diagnose a small intestinal tumour. You'll come across these terms often in the indication for a CT scan: staging and restaging. So staging is where we define the extent of disease, usually at diagnosis or baseline. So that's where is the disease and how much disease is there. Restaging is when we reassess the disease, usually following a treatment or a period of treatment or a change in treatment. CT is also used to define the anatomy, particularly if we're considering resection. So, for example, it's particularly good at defining vascular anatomy, and that's the blood vessels in relation to disease, which can tell us if something is it going to be able to be operated on or not, and what the complications of that operation might be. So its advantages: it's readily available, it's very quick, it's easy, there's not a lot of complications, it gives us excellent, exquisite anatomical detail, and it allows us to perform accurate measurements. From a monetary point of view, if people were interested in, it's significantly cheaper than some other modalities such as MRI or PET-CT, for example, and has a lot less ionizing radiation dose than PET-CT. The disadvantages: it does involve a degree of radiation, and that's more than other modalities. For example, ultrasound and MRI don't involve ionizing radiation. There's no functional information, which is what we'll talk about coming up. The size of a lesion doesn't always correlate with the activity of a lesion. So sometimes we can see a tumor grow, but actually that's not because of turning over active cells. It might be because a tumor has died in response to treatment and there's been accumulation of fluid within the space where the tumor was. And it can also be sensitive to technical factors. So we rely on being able to see the tumor being of a particular density relative to the normal tissues around it. And that's really reliant on how it appears following intravenous contrast. And that's something that can be quite sensitive to the timing of the scan. So this is your kind of typical picture you might get from a CT scan. And this is what we call an axial or horizontal plane. So this is a round image here, which is a cross-section through the patient. So this is the front of the abdominal wall, and this is the back of the abdominal wall here, and these are the buttock muscles here. This is coming down into the pelvis, just above the hips, and this is the sacrum, just above the tailbone. So on this scan, we can see lots of things which look grey. But these are all different kinds of structure, and we rely a bit on the enhancement, how they change colour basically after we give them contrast, and our knowledge of anatomy. So for example, these are the gluteal muscles, seen back here on both sides. And these squiggly bits in the middle here are all loops of bowel. And this here, if I can convince you that you can see a slightly whiter, brighter little backwards C shape, that's a small intestinal neuroendocrine tumour. So this is in the same patient, and this is what we call a coronal plane. And so that sort of comes in a front to back orientation through the patient in this sort of frontal plane. So in this kind of plane, we can see we've got the liver here in the right upper quadrant. We've got the hip bones here and coming through to the pubic bone. And we can see that same little reverse C-shaped knuckle of white, bright, enhancing small bowel tumour. CT is also really good for looking at the lungs. It's excellent for looking for pulmonary nodules and masses. This, for example, is a picture of a patient, left lung here, right lung here. This is the bottom of the trachea, and this is the airways on the right. And it should be this black tube, black as air. We should see a continuous black tube, but on this side, there's a little nodule sitting here within the airway, and that's a pulmonary or lung neuroendocrine tumour. These ones are sometimes called carcinoid tumours, which is just an older kind of terminology which was used. So CT, what to expect? You'll sometimes, not always, depending on the site, asked to be nil by mouth for 2 hours prior to the scan. That's an older protocol that we had, and I think most departments are phasing that out now. And the reason for this was because sometimes when you have intravenous contrast, it gives you a set of odd feelings. You often get a bit of a hot flush. Some people get a metallic taste in their mouth. Some people feel a little bit nauseous, and some people get a feeling like they've wet themselves, like they've passed urine. But you haven't. It's just the feeling of the intravenous contrast going through the veins in the body. To do that, obviously, we need to have an IV lure, which will be inserted in the hand usually, or the into the antecubital fossa, and I can't think of the layperson name for that right at this minute. But the whole scan is really very quick. It takes about 5 or 10 minutes to do a scan, even a multiple phase scan. And the other good thing about it is that it is what I call the donut, as in it's a really short tube. You don't have to be all the way in it. Usually your head will be poking out one side or the other, and it's got a nice big hole there, so people don't tend to feel claustrophobic at all. Okay. MRI is another kind of scan. This one is used mainly as a problem-solving technique. We use it for doing things like characterization of liver and pancreatic lesions. So when we see a lesion on the CT, sometimes it's not possible to say what kind of lesion that is. We can see a liver lesion and we might say that could be a lesion that started in the liver. It could be a lesion that's metastasized to the liver, or it could even be a benign lesion. And MRI is one of the ways that we can problem solve and to characterize those kind of lesions. It's also more sensitive than other techniques for detection of liver lesions, even more sensitive than PET-CT. And it can see lesions that are down to, 2 millimeters, 3 millimeters in size. So it can be very important for preoperative planning. For example, if we see a lesion in the liver and it seems to be the only lesion on CT, we want to know if there are other smaller lesions elsewhere, because it can change the surgical approach and it can sometimes change whether we can even do surgery at all, whether it's worthwhile. It's also, in other settings, very sensitive for bone lesions, so some patients may have an MRI of their spine to look for bone disease. And it's got a definite role in surveillance in young patients. So we have patients who have neuroendocrine tumours who have a genetic syndrome, and those patients will need imaging over many years. And for those patients particularly who are often known about from when they're very young, it's really important that we don't use too much ionizing radiation. So what to expect from an MRI? There's usually no preparation beforehand. You usually will have an IV lure again in the arm. There's different kinds of contrast that we use, and those have different uses and different reasons that we use them. So you may, for example, find yourself being referred for an MRI and think, but I had one, not that long ago. But there are different kinds of contrast that we can use for different purposes. So that may be a reason for what feels like a scan which is being repeated. The MRI, as opposed to the CT, is more of what I think of as a toilet roll shape, unfortunately. So it's quite a small hole. It's usually or often you may be all the way within this tube, and some people find it a bit claustrophobic. It's usually a much longer procedure, and some scans can take up to sort of 45 minutes in length, and it's very noisy. The MRI machine makes a whole lot of what sound like very random banging and clanging noises. But if people have trouble with the small space or they're nervous, which many people are, we can give sedation, which really helps most people to tolerate it very well. We don't have many patients who can't manage an MRI at all. So this is a picture of an MRI machine, and you can see the length of that there. So often, most, if not all, of the patient will be inside the machine. So an MRI produces many different sequences that we look at, and each of these has a different purpose. So you can imagine this is not even all of the sequences from one liver MRI. So it gives you an idea of how much information there is to examine and compile and put together in a single scan. But it can just give us a lot of information about the kinds of lesions we're dealing with, and is just exquisitely accurate in terms of size. So we can examine large lesions, but we can also detect lesions which are down to about, 2 or 3 millimeters, which you're just not going to see convincingly on any of the other modalities. So moving through now to what we call functional imaging. In functional imaging, the mainstay of that is PET-CT. So PET stands for positron emission tomography, and is what I was talking about before with the sort of lock and key analogy. So what we do is we tag some radioactive material to a key, and then we find a target for that key to fit into on the surface of a cell. So the key fits into the lock, that specific lock, the receptor on the surface of a cell. It binds to it, and then once there, the radioactive material breaks down into smaller parts. Now those smaller parts are detected by our PET machine. And we then use that PET machine and the images from that PET scan, and we match that up with images from a CT scan to show us exactly where those radioactive little blips are coming from. So where are those cells that have those receptors on their surface? So the two major kinds of PET-CT that we use in neuroendocrine tumours are the somatostatin receptor, SSTR PET-CT, and then FDG PET-CT, which I'll talk about a little bit later. So somatostatin receptor PET-CT. So this utilizes the fact that neuroendocrine tumours have somatostatin receptors on their surface. And in fact, they usually overexpress those receptors. When I say overexpress, it's because there are lots of normal organs that have cells which have somatostatin receptors on their surface. So, for example, the pituitary gland, the salivary glands, the liver, the kidneys, the spleen. And in healthy cells, those receptors, like I said, are part of that signaling system to regulate hormone secretion. Neuroendocrine tumor cells, when they overexpress these receptors, it means they can overproduce hormones, which can lead to some symptoms in neuroendocrine tumors. So our SSTR PET-CT scans are called GAT8 or dotatate. You might hear either of those terms. And basically, we use octreotide, which is something that mimics somatostatin, which is the key, and we bind it to gallium-68, which is a radioactive material. So that combination binds to the somatostatin receptors, which is the lock, on the surface of the tumor cells. The radioactive material breaks down, and we detect where it breaks down and match that to the CT scan. So this is that same picture, just with a little addition of our particular labels, the gallium-68, the octreotide, and the somatostatin receptor on the surface of the neuroendocrine tumor cell. So each of these studies gives us thousands of images. So we get images like this, which are the PET component. So these ones look a bit grey, a little bit grainy, and all of these areas that are a bit brighter are areas where the radioactive material has bound to somatostatin receptors on the cell surface and has broken down and released that radioactive material. So these are all sites that have somatostatin receptors on their cell surfaces. So we get the PET scan, and then we get CT scan as well. And we can use those to match up those sites, and we can produce fused images like this. So, as I mentioned, there's lots of normal sites of somatostatin receptor expression. So those are these ones which we're seeing on this scan. So in this kind of scan, we usually scan the patient lying on their back with their arms above their head. We see normal uptake within the pituitary gland, which is an endocrine gland in the brain. We see normal uptake here in some of the salivary glands and down in the thyroid gland. We can also see normal uptake here within the liver, the spleen, which shows the most intense uptake, the kidneys, also the adrenal glands here, which are some other little endocrine glands which sit on top of the kidneys. Also within the bowel, we get some physiologic or normal uptake. This is excreted radioactive material that's been excreted by the kidneys and is mixed in with the urine and has gone down to the bladder. And we see a little bit of uptake within the prostate gland as well. So in terms of PET-CT, we usually do the GAT8 PET-CT just before the patient's next dose of long-acting octreotide, just because octreotide will also bind to those same somatostatin receptors, and we're trying to prevent that interaction between those. Usually there's water only for 3 hours prior to the scan, so nothing solid to eat. And after injection, we usually scan the patient around 45 to 50 minutes later. This is done with an IV Lua in as well, and we give intravenous contrast again so that we can get those detailed, accurate CT images and really make that correlation as accurate as possible. You're usually on the table being scanned for about 25 minutes, and the whole thing from start to finish is about 2 hours or so. It's important to note that you'd be radioactive for about 5 hours after the scan. And so that's really important if people have young children at home. Obviously, if you're planning on traveling, if you're from out of town, you wouldn't really want to be getting on a bus or a plane, which might have, young children or pregnant people. So some of the phrases you might hear in GAT8 PET CT, one of the common ones is AVID. And this just means that a site lights up on the scan. So we can see if we go back just a couple. So all of these normal structures are showing avidity. They're, varying shades of white bright. They're lighting up on our scan. So that's what the term avid means. And that avidity correlates to how many receptors are on the surface of those cells, so the receptor density. And we can describe that in both quantitative ways, so that's using a number, which is the SUV max, and that's just standardized uptake value. But we can also do it in a qualitative way, which is a comparative score. So we use something called the Krenning score, which is where we compare the uptake within a lesion or a tumor against sites of physiologic or normal background uptake. The Krenning score ranges from 0 to 4, with 0 being no uptake at all, and 4 being greater than the spleen. An example of that is here, where we've got a pulmonary carcinoid. So this is a nodule within one of the airways of the lung. We can see that it's got uptake, so it's not a 0. It's not lower than the liver. In fact, it's definitely more than the liver. It's brighter, it's whiter. And in fact, it's even brighter and whiter than the spleen. So we can say that that's Krenning 4. So the roles of GAT8 PET-CT are these ones that I've listed here. So we use it for a lot of different things. And I'll just go through those one at a time. So first, confirming or excluding a diagnosis. Large bowel, but the gas that we put in for the large bowel study actually outlined the small bowel as well. And we found a little tumor within the small bowel. And just beside that, we found a tumor within the mesentery. So the mesentery is just part of the connective tissue which holds the bowel in place. And it's got fat in it, which is this dark stuff. And it's got little blood vessels, and it has some little lymph nodes. And this is a tumor deposit from a small bowel neuroendocrine tumor. This is what they typically look like. They often have a bit of calcification, a little bit of bone formation almost within them. And so on this patient, you can see that everything that we're looking at here is really central within the abdomen. It's got all of these loops of bowel overlying it. There's been no way to safely biopsy that and to prove that that was a neuroendocrine tumor without performing quite a big operation. So we were able to do a GAT8 PET-CT in this patient. And this is one of those fused images where we've put the CT scan with the PET scan. And this is the small bowel tumor here. And you can see that that's really bright. And then we've got that disease in the mesentery, and that's also really bright. So without using a needle, without having to put the patient through a risky procedure, in this case, we were able to prove that this was almost certainly a neuroendocrine tumor, and the patient was able to proceed straight to surgery. On the other hand, we have had other patients who've had tumors which have looked kind of like this mesenteric disease. Maybe not quite, but we've gone on to do a PET-CT and shown that that was absolutely no uptake in that on PET-CT, so it was very unlikely to be a neuroendocrine tumor. And those patients have a different management pathway. We use GAT8 PET-CT also to localize primary disease. So sometimes it's difficult on conventional imaging to find the primary tumor. So for example, this is one scenario we might encounter. This patient had had a previous resection of a neuroendocrine tumor from the far end of their pancreas, but they represented with recurrent symptoms. So they had symptoms which were due to a secretion of a hormone. They were exactly like the symptoms they'd had the first time, but we couldn't find a tumor on CT. We did this GAT8 PET-CT, and you can see this tiny little white dot here, which localized to a part of the pancreas called the uncinate process. And then that allowed us to go back on CT and find this, I think it was about 5 mm, very subtle abnormality, which you just couldn't spot without that guidance. This is another scenario that we sometimes encounter. So this patient had a liver lesion identified. We did a biopsy of that, and we found that that was consistent with a neuroendocrine tumor, but not likely to be a primary one arising in the liver. It was almost certainly a metastasis from another organ, but we couldn't find it on plain CT or MRI. And so we did a PET-CT, and that confirmed that the liver lesion was of neuroendocrine tumor origin. But it also showed us this area of uptake within a small bowel loop. And even going back on the CT, we were unable to find that on conventional CT, and that turned out to be the primary tumour. Another role in terms of detecting primary or primary tumours is the fact that many neuroendocrine tumours of the small bowel are what we call multifocal. So there may be many small intestinal neuroendocrine tumours. In fact, I think about at least 10%, might even be higher than that, of neuroendocrine tumours of the small bowel will be multifocal. And the most number of tumour deposits within the small bowel that I ever had one of the pathologists find was, I think, 110 tumours. So that was pretty impressive. GAT8 PET-CT is really useful for defining the extent of disease. So whether something's localized within one region or whether it's metastatic, and how much disease there is in various sites. So this was an example of where we can see multiple areas of uptake within the liver, all of these bright white spots here, and that's just on the same thing on the fused image. But in fact, this patient's liver disease was really subtle on the CT. We could see at least, one or two lesions, but nowhere near as many lesions as we were able to visualize on the PET-CT. Another really strong point for GAT8 PET-CT is its detection of bone lesions. So bone lesions in many cancers are relatively easy to spot on CT. So the lesions, the metastases will destroy the structure of the bone. But in neuroendocrine tumor metastases to bone, they're often really, really subtle. We can often not detect them on the CT scan at all. Like this example where we see this definite metastasis here, and there's just nothing that you could see prospectively or even retrospectively in that area on the bone CT. So it can be very sensitive for bone disease. GAT8 PET-CT, another huge role is to define and guide our treatment decisions. So we use it to define the somatostatin receptor expression on tumours, and therefore direct patients to the most suitable treatment, whether that might be PRRT, which I'm sure you've all heard about, or chemotherapy or surgery. It tells us if the disease is going to be suitable for treatment by one of those modalities or not suitable, just as importantly. So, for example, this patient has tumours involving the liver and lots of tumours involving the bone. And you can see that those are all very white and all very bright. They're much higher uptake than spleen. So they've got a lot of somatostatin receptors on their cell surface. And this would be a kind of disease that's going to be really appropriate to treat with PRRT, because it's going to target, in a similar way to the scan we do, it's going to target those cells. The counterpoint to that is that sometimes we expect tumours to have that somatostatin receptor expression, and they don't. So this, for example, was a case where there was a lot of disease in the liver here. All of these dark spots are liver metastases. But when we did the PET CT, you can see that that's not white and it's not bright. It's not avid at all. This is normal background liver, so it's actually less avid than background liver and much less avid than spleen. So there's no point in this case treating with PRRT because it's just not going to work. And in this case, chemotherapy may be a more appropriate treatment. It might yield a much better response. So we use GAT8 as well to look at response to treatment. And here's an example. This was a case where there was a lot of disease within the bone. The patient had 4 cycles of PRRT and had a really good radiological response. You can see that all of those bright white spots have either gone away or become significantly less bright and less white. I would say, though, that we always take into account not just the radiological change after treatment, but also biochemical change. So that might be if the patient has a marker, a blood test marker that can be followed, but most important, the patient's clinical response. So frequently we will see a scan after PRRT, which might look fairly similar to the pre-treatment scan, but often in that setting, the patient will have had a dramatic clinical response. They'll feel much better in themselves, and that's really the important thing. So there are some pitfalls and some limitations in PET CT. As I mentioned, there are those areas of physiologic uptake, normal background uptake, which can make it difficult at times. Some other pathologies can demonstrate GAT8 avidity. So things, for example, like inflammation or infection can show GAT8 avidity, although it's usually at lower levels than tumour uptake. Conditions such as sarcoid and some benign lesions such as meningiomas or some bone diseases like fibrous dysplasia. Small volume disease, as I mentioned, MRI liver is very accurate for small liver lesions, which are not going to be as well seen always on GAT8 PET CT. And then poorly differentiated disease. So most tumours, neuroendocrine tumours, are what we call well differentiated. And that means that all the sort of normal components of a cell are in there and they're all doing their job, producing the somatostatin receptors, which we can see on the PET scan. But some tumours are higher grade and they lose that differentiation, they lose that normal cell architecture and normal cell functions. And with that, they lose the expression of the somatostatin receptors on their cell surface. So those scans, those kinds of neuroendocrine tumor, which might be called neuroendocrine carcinoma, are not going to express somatostatin receptors on their cell surface, and therefore they're not going to be tumors that can be treated with PRRT. So the other kind of scan that we use in neuroendocrine tumours is the FDG PET CT. So in this situation, instead of attaching the radioactive material to a somatostatin analogue, something that's going to bind to a somatostatin receptor, we attach the radioactive material to a sugar molecule. And that provides us information on the metabolic status of a tumour. So how fast are those cells growing? How fast are those turning over? That can give us an idea of how fast a tumour will grow and how it will behave. And it can also help us guide treatment. So these are another couple of terms that you might hear. Concordant disease. So that refers to disease that's GAT8 avid and FDG avid, as opposed to discordant disease. And that's disease which is not GAT8 avid or not very GAT8 avid, but it's FDG avid. So disease that's concordant will generally respond well to treatments like PRRT, whereas disease that's discordant will not respond well usually to PRRT and may be growing more quickly or aggressively. And these are tumours that are often directed towards chemotherapy rather than PRRT. So at baseline, this can give us sort of prognostic information about how we think the tumour might behave, and what treatments are going to be most appropriate. So for example, in this case I showed you earlier where we had the liver metastases, which didn't demonstrate adequate GAT8 avidity, they were metabolically active. So those were showing greater cell turnover and use of sugar than background liver. And that's often matched up with changes we see on CT, in that lesions like this might be growing quicker. So in summary, I've kind of tried to just walk through what you might experience in some of the different scans that you'll encounter, like ultrasound, CT, MRI, and PET CT. And hopefully I've covered a little bit of what we use them for and why, and what their advantages and disadvantages are.
Thank you so much, Jane. I'm always in awe of your ability to talk through all of this information in such an easily understandable way without and all the way. It's just so clear and so concise and precise. So thank you so much.
Oh, thank you very much for inviting me to speak. It's an absolute pleasure as always, and lovely to see all your lovely faces.
Awesome. Thanks, Jane. Ka
Okay.
kite, everyone.
Pleasure. Bye.